Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
Thank you, Siri, and everybody else for inviting me here. I'm actually grateful for the opportunity to talk about what we do for kids with advanced lung disease, because believe it or not, there's a few of them out there who prior to becoming adults and sometime in the middle of middle school, they have various illnesses that advance rapidly, and we have to treat them and hope that they can continue on with productive lives. And sometimes it takes a lung transplant to get them to continue on to productive living and good quality of life. So I'll explain that a little bit. I have no financial disclosures to make. So just for a little bit of history, heart and lung transplants have been around since about the early 80s, and Stanford is the place where it was developed quite a bit in the early days. And so this is a picture of Dr. Bruce Wright's operating. He was the surgical fellow at the time, operating with Dr. Norm Shumway, doing the world's first successful combined heart-lung transplant on March 9th of 1981. It took him 4 hours, and the heart and lungs of an anonymous donor were implanted into Mary Golke. She was 45 years old, a newspaper executive from Arizona. She did survive, but 20 days, and the biggest obstacle at the point was really immune suppression and mastery of that, and that hadn't been really perfected yet, and most of the meds had not been developed. But again, the transplant science was pioneered at Stanford, and prior to heart-lung, just a heart was first transplanted in the U.S. in 1968 by Dr. Shumway. And the team was Drs. Shumway, Starnes, Stinson, and Wrights, and they did the first heart-lung in 1981, as I said. Then the procedure moved on into smaller people, into children in 1988. But a single lungs alone into a child was in 1986 in Philadelphia. A 14-year-old with interstitial lung disease was done, and our first one at Stanford was in a 1-year-old baby with, I think, bronchopulmonary dysplasia, which is something that premature infants can develop, and that was in 1990. This then places us as the oldest lung transplant, a pediatric lung transplant program in the U.S., and currently we're the only standalone pediatric lung transplant center on the West Coast. The next closest one is in Texas. It in fact is quite a rare procedure. There are 19 centers in the U.S. reported at least one pediatric lung transplant in 2016, and that's for children up to the age of 18. But there was a total of 38 lung transplants done that year. But there has been a decrease in the total number of lung transplants. We've gotten much better at managing disease. Patients who really work hard and adhere to their medical regimen, and so as of 2017, it's pretty much leveled off at about 41 lung transplants in children, but fewer centers are doing them. The adult centers used to do teenagers, but it's obviously psychosocially better and clinically a better idea, I think, for children to be transplanted at pediatric centers. We understand their issues better. And so far in 2018, 30 lung transplants have been reported, so we will probably not exceed anything. And globally, the number of transplants are decreasing. So as you know, the first heart-lung transplant, pediatric heart-lung transplant at Stanford was in '88. When I started working there in 1995, I believe, we didn't actually have a pediatric lung transplant program. The adult surgeons, again, were seeing the children, and they were becoming younger and younger, and they had requested basically that pediatric pulmonologists become involved because the procedures for performing biopsies are tough, and at least to an adult and small people, and so I was trained to do that, so they asked me to come on board. So again, this is just a timeline, and this is about when we were established as a pediatric lung transplant center. And I joined this international pediatric lung transplant collaborative with only maybe 30 to 50 transplants of children in a year. You need your friends. And so we have a nice collaborative group. So we do lungs, heart, lungs, and really dual organ, solid organ transplants happen as far as the most organs received. We doing 3 tends to be quite challenging, and resources are scarce. But so we have done a pediatric lung liver that was way back in 2011, and I'm happy to say my patient has been transitioned to the adult program. But I don't know if anybody's familiar, but that some people who are awaiting transplants, so you know that people who need a kidney transplant might get dialysis until the time that they finally receive a donor. So people's hearts can fail and people's lungs can fail prior to getting a transplant. And so new techniques and surgeries are being developed to sort of mechanically assist people as a bridge over to transplant. And so there are different ways. And our first experience was with this device that we call the left atrial to pulmonary artery shunt, so usually the blood comes in through the right side of the heart, goes through the pulmonary artery into the lungs, gets oxygenated, and then comes back to the left side of the heart, with the heart making all that happen. This particular patient had very high blood pressure in his lungs, and we call that pulmonary hypertension. His heart was failing, and he was in fact hemorrhaging into his lungs. And in order to help him survive, we implanted this device that basically had a filter where oxygen could be pumped into the blood using the patient's failing heart. It was strong enough at least to put it through this low pressure filter and evade the lungs, the high pressure. And so the child survived, and that's him and his dad. It's probably not the best, biggest picture you've seen, but it's him with the device in place. And a week later, he was lucky enough to get a great donor, and he too is still alive. So as far as the pediatric lung heart transplant goes at Stanford, 2002 is about when I joined the team. 2004 is when it became official. We had a pediatric lung transplant program by itself. And in 2009, we completely separated from the adult service. And so at this point, our transplant physicians are myself, Dr. Mila, and Dr. Cornfield. We're all pediatric pulmonologists. And our transplant surgeon is Dr. Maeda, who is fantastic. And my care coordinator is Lale Razai Homami, who is incredibly meticulous and has really been key to our success. And it takes a village, as we all know, and so we have nutritionists, social workers, psychologists, physical therapy, respiratory therapy, and whatever ancillary services need to be included, say nephrology or cardiology, what have you. Most of our referrals come from the west, southwest, and northwestern parts of the United States. We basically, if patients are referred to us, we do quite a bit of evaluation, and we prepare these kids as best as we can to succeed with the transplant. They tend to be malnourished and in poor working sort of physical condition, and we try to maximize their ability to basically get through a surgery as major as this, and insist that they also know after the procedure they'll be up and walking within about 2 or 3 days. For most, that can happen. For many, it takes a little bit longer depending on their health. But this is just a map that sort of circles the region of referral to me, and you can see that here we are in California, and the next place that is purely pediatric is way over there in Texas. And most of the other centers are in the east and northeast. There's a lot of different reasons than disease entities by which people get referred to us who have failing lungs, and it varies by age. So in infants who are referred, they're generally referred for heart-lung transplant, and the main reason these days are mutations in proteins that help your lungs stay open and exchange oxygen, called surfactant is what allows your lungs to do that. And there's mutations in the proteins and the ability of cells to properly make surfactant. Some of these diseases are lethal and others present less severely, and thus we have time with which to list them. Other diseases of pulmonary fibrosis, it's not similar to the adult form of scarring of the lungs. There are other reasons for that. And the pulmonary arterial hypertension is often related to, again, a prematurity condition or congenital heart disease. But things start to shift at 1 to 5. Cystic fibrosis starts to maybe become a thought, and again, things are so much better managed from a medical standpoint that even for people who are severe, we can often hold off until they're at least 6 or between 6 and 10. But the next major category is, again, these people with high blood pressure in their lungs, called pulmonary arterial hypertension. And this scarring, again, can happen related to the surfactant deficiencies, other types. Surfactant B tends to be quite lethal, and kids don't live that into their 1st and 5th year. But like I said, there's less severe things. When kids are 6 to 10, then cystic fibrosis is about 50% of the patients who require transplantation at that point. The pulmonary hypertension becomes more prominent. Obliterative bronchiolitis is sort of like CF without all the infection. And you can get that after having experienced a normal kind of pneumonia, a viral pneumonia, exposure to things that get breathed in. There are unfortunate incidences of that. And then into the teen years, CF is by far and away the major reason for it, need for transplant. So what we tell the medical community is refer early and refer often. Because as soon as they know that their kids are diagnosed with these pretty much end-stage diseases that are going to progress that way, we like them to come to us so that we can buff them up and make sure that there aren't other procedures available or that there aren't medical treatments that they may benefit from at our, we have a pediatric pulmonary hypertension center, an amazing cardiology center, and so we can oftentimes buy kids some years. But should they have to get a transplant, we'll take them in and send them back into their communities after a period of time when it's safe. This slide basically shows the donor type of distribution with the recipient age, and most transplant recipients are adolescents and most donors are adolescents or young adults, which can make it a little tricky for the younger kids. We're always hoping to raise awareness and increase younger donors. So this is also a tricky slide. It's sort of backwards the way I look at it. So instead of seeing increasing numbers of referrals to our centers, this actually reads the other way. So that you can see, so that St. Louis Children's and Texas Children's do the most. They're very large centers, have large catchment areas, and do somewhere between 10 and 20 pediatric lung transplants a year. But everybody's decreasing in the number of procedures they're doing at each center. And so in 2014 we did 5, and in 2016 we did 3, and pretty much on average we do about 3 children a year. Mostly just lungs, but we're one of the few centers who will also do a heart-lung if necessary. And so this sort of shows globally what the total number of reporting centers. You can see in the sort of mid-2000s, the high done was about 125.7. There was 137 done in 2013 that was reported to UNOS. But again, globally, it's dipping, and we expect to have maybe again 95 or 100 again this year. So the outcomes are generally good, but there can be quite a few complications, and especially for children who need that mechanical intervention to bridge them to successful transplant. So primary graft dysfunction is a term that implies that the lungs really aren't oxygenating well. They're a bit dysfunctional. There's a lot of reasons for that, but the higher the grade, that is, the lower the long-term survival of the patient is. But there's been a lot of improvement in preservation techniques, surgical techniques, medical management. Nonetheless, the median survival at 5 years is about 50%, 60%, depending on the era at which the surgery was done. And to be quite honest, even with the improvements in immune suppression and these surgical techniques and preservation of the organ, it happens that the graft just becomes dysfunctional, and we are basically still looking to see why that is. It has a lot to do with the fact that lungs receive everything that we breathe. And so you walk by somebody smoking and you have just received a lung transplant, your immune system will react. So there's pollution to deal with, infections, and just plain living is hard on the graft. We're at our center, we have about 65% survival at 5 years across the country and across throughout the world. It's closer, if you just average everybody, it's about 50%, 50, 55. So we have good outcomes. And again, I think it's my nurse coordinator who's responsible for that. So this is a happy picture of some recipients. So again, this was the kid who got the PA to LA shunt. This is a boy who came in who damaged his lungs while he was swimming in a swimming pool. Otherwise fine. He developed acute respiratory failure after getting a little pool water in his lungs. And so he was put on this, what we call ECMO, otherwise known as extracorporeal membrane oxygenation. Big words for something that's oxygenating your lungs that your lungs can't do. And it also acts a bit as a pump like the heart. The veno-venous methodology mostly bypasses the lungs and relies on the heart to function fairly normally. So this little lucky guy actually was on ECMO and walking around the ward with about 20 people around him. And he rehabbed to the point where he didn't need the ECMO anymore. And he however, you can see that he has a tracheostomy there, and these are the lines of ECMO going into his chest, and our surgeon has developed a technique called central access with the catheters, so that it allows people to move and to walk. I mean, that's what is essential, and that's why this boy recovered. He was able to do rehab. This cute little person has CF, and she went directly into respiratory failure pretty quickly after she was listed, and she was able also to rehab, but we knew her lungs were never going to recover, but she lived to successfully receive a transplant. So this picture was taken, I think, like 3 weeks ago or something. So that's our cadre, and like I told you before, this kid had the shunt, and he received a heart-lung, and he had severe PGD, that primary graft dysfunction afterwards, but he somehow pulled through that, and he's now 4 to 5 years out. I think it's 5. So, it's miraculous to me that we're able to do this. But there is also the future of lung, those mechanical devices are not perfect, and there can be lots of complications with that. So there is a group in Toronto that harvests donor lungs. Not all the lungs that come in are perfect. The donor may have contusions on the lung or have had an infection or something, and so we're not really sure about that it's going to make a good donor. So they put these lungs basically in this box and hook up the arterial and venous lines. They put the lungs on a ventilator, and you can see the little lungs getting bigger and smaller, and they perfuse with solutions that hopefully sort of revive the organ and kind of make it better than it looked to begin with. And 20% of the time that actually is successful, and patients have no different survival. So that's something that is not being developed in pediatrics, because for 3 kids a year, you need a whole second team to back that up, and so it's really not a cost-effective sort of way to approach that. But it's incredibly interesting, and so I had gone to Toronto just to see that. And this, again, is another cute recipient. That was her about 2 months after her transplant. She's doing pretty well, too. And this is a family. She received her transplant. They have CF. She received her transplant 3 years before her brother needed one. And they, too, are doing really well. And they wrote letters to their donor and talked about, how their life is different. And David's little statement says that he says, "Thank you for my new lungs. I can breathe better, and now I can go outside and play with my sister." New lungs are a new life. And Doris had said that she's very glad that she's done with all of her coughing. She has new lungs and has to take care of them. It's still a long road afterwards, and they really do have to continue to do their airways clearance. They take a whole nother set of pills. But it is successful, and so we're glad to help people get through that. Yeah, so there is an average amount of time that we tend to quote to patients how long they may wait for a donor. A good donor depends on your blood type, your height, and those are the two main things, to be honest, and how sick you are. There's a score that is calculated depending on your lung function, if you have diabetes, if there's like 12 different parameters that go into there, and the frailer you are, the higher your score. The higher your score, the more likely you'll be first notified of that donor availability. That's how they decide who gets what. And this system was started in 2005, I believe. But that applies to people 12 and older. Children are listed as an adult at the age of 12, just basically they're sort of competing for the adult donors or the adult candidates as well, but not really, because they're half the size. And so it's so small. Like I said, children as donors are pretty rare indeed. And I think that it's probably through a lack of awareness, and also the donor's mode of demise is if someone is in a car accident, they are probably not a good lung donor, say. And for infants, it's even less common, right? So I would say infants, we quote a 1 to 2 year wait time, and depending on the disease process, that's either feasible or not. And for the kids who we recently transplanted, they were quite small, and so Doris waited I think over a year, and David waited 2 months, and he's this big. So it's hard to say really when it's going to happen, but we always plan on them being there longer and waiting than not. And we do ask them to transplant themselves to our area, because the sicker they are, the less capable they are of flying in an airplane and actually surviving through that. So that's why we have them move up, and it is a huge hardship on the families, for sure. So the median age of CF has risen into like 42, I think, years at this point, which is huge. When I was a resident and a fellow, when I was a resident, the lifespan was somewhere under 20 years. And then with all the developments that have happened through research at the CF Foundation and contributions from all the research institutes, survival has incrementally increased. And initially it really wasn't rocket science. It was antibiotics were being developed, and we understood nutrition better and didn't allow people to fall off the growth curve. And all techniques for doing airways clearance, like things like that, really enhanced the survival. And so up until about 5 years ago, we had a pretty good idea that close to 100% of CF patients would have to consider transplant. The new medications that are developed by Vertex and other companies are life-saving for a small percentage of patients and can really turn the disease around so that nutritional status and pulmonary status revert to normal. But for patients who have 2 copies of the Delta F508 mutation, confers upon them not really good response to those medications. However, it does seem to confer stability. So now the question is, how effectively does it do that? How long does it do it? And then when do we expect to see decline? Who knows? People will probably do much better for much longer with the development of those meds, and there's a whole lot more that are being developed. It's really interesting and very sort of encouraging. So.